Hey guys, this is Aaron with Ross Training Academy. Today we're just going to be going over the patient assessment. This is going to be for the BLS and for even the ALS level. Patient assessment stays basically the same for every provider level. Just your scope of practice and what you can do to help the patient starts to change. The patient assessment is a very important part of our job in EMS. You know, we are the first medical provider that might see this patient, and so what we see, what we hear, what we find, what we treat, that's going to be all very valuable information to share with the hospital once we transport this patient. And with patient assessments, you are going to have to do one on every single patient that you run on. So this is something that does take time to form and get good at, but it is something that we need to try to get good at. So this video is going to try to explain all of these little bullet points just a little bit. It is going to stay relatively basic, but hopefully it gives you a better idea going into class, or hopefully a refresher for your class. So at your school, when you're getting signed off on your patient assessments, they are going to be looking for this critical criteria down here. These are going to be critical fails. And so it doesn't matter how good you're doing, how many good points that you're getting over here. If you hit one of these critical fails, well, then you fail the scenario, and you should have to retake the scenario. So feel free to pause the video real quick and just read over this critical criteria. All of that stuff is going to be pretty self-explanatory, and a lot of it is going to be covered in your EMT class or in your advanced EMS class. And so as long as you're not doing anything egregiously wrong, you shouldn't hit any of these critical failures, as long as you stay with what is taught in your class. So let's go ahead and get into it. The first thing is going to be takes or verbalizes appropriate PPE precautions, personal protective equipment. So things like your gloves, your gown, your surgical mask, your N95 mask, your goggles, face shield, things like that. Just depending on your scenario or your dispatch information, you'll have to decide what you think you might need for that particular call. And in real life, your PPE should be something that you have on or getting on before you get out the ambulance or before you even touch a patient. And then going down to the scene size up, you're going to determine if the scene is safe or if the situation is safe. Scenes are very dynamic. A safe scene can very quickly turn into an unsafe scene. So you need to make sure you're scanning your environment as often as possible. You know, a dispatch information or a dispatch call of something as simple as a dog bite, you need to think of scene safety. You need to think of where is this dog, what's the size of the dog, and just stuff like that. A very simple sounding call, you still need to think about your scene safety. And then going down to determine the MOI or the NOI. This is going to be a medical scenario, so we know it's going to be a nature of illness. And then in real life, from the dispatch information, you'll be able to kind of decide for yourself if this is going to be a mechanism of injury or a nature of illness. The next thing down is going to be determine the number of patients. That is something you want to do because that will kind of change the way you have to treat and triage people, and it will start to change the amount of resources you might need on scene to help deal with all the patients. And you want to make sure that you aren't missing any patients. So at that car accident scene where the windows are broken out, make sure you do a very good, thorough 360. Make sure nobody got ejected out. So that example is more for trauma, but even for like a medical call, if you go into a house and there's 3-4 people complaining of the same type of symptoms with the same sort of onset, that's going to start changing the type of call it is and what kind of resources might be needed. So the next point down is going to be request additional EMS assistance if necessary. So you might have to call for additional ambulances. You might have to call for ALS. You might have to call for a critical care helicopter or ambulance to show up. You might need the fire department there. You might need police there. You might need animal control. You might need the utility company. Those are all going to be some examples of the assistance that you might need, and that's going to be something that you're thinking about on the way to the call. But of course, once you're on scene and you evaluate the scene, you want to also be considering that stuff. Maybe if you already called for them or had them on standby, maybe start considering canceling them or launching them. But yeah, so moving down to the next point, consider stabilization of the spine. That's something that you're always just going to verbalize for your school scenarios. I'm just going to consider C-spine precautions. Or you can say something depending on your school. This doesn't seem like a trauma-related illness, so I am not going to stabilize C-spine at this time. And then moving on to the primary survey, You're going to have to verbalize your general impression of the patient. This is, again, just going to be for a school thing. Just your general impression of the patient, what you see of the patient, what you see on scene. You'll say, I walk in and I see the patient in the tripod position. I see them holding an inhaler. They seem to be in distress. It'll be something as simple as that. The next thing down is going to be determined the level of consciousness or responsiveness. And the way you're going to do that is you're going to use this acronym AVPU. All AVPU stands for is alert, verbal, pain, unresponsive. And what that means is, and you are going to use this on your real 911 calls or your transfer calls. So the A, the alert, you walk into the room. Is the patient looking at you? Are they tracking you? Are their eyes open? Do they greet you as you walk in? That's just going to be alert. The next thing, the V or the verbal, this person might be lethargic. They might be kind of looking off to the side. Their eyes might be closed. But when you talk to them, do they perk up? Do they respond to you? Do they acknowledge that you're there? If they do, then they're going to be alert to verbal because they need to be spoken to become aroused. And then we have our P. The P is just going to stand for pain or painful stimuli. So is this person lethargic, not tracking you, eyes closed, and you go and you do that nice old sternum rub, right into the center of their chest, cause some pain? Do they respond to that? Do they acknowledge you after that? If they do, they're going to be responsive to pain. If they don't, they're then going to be you, and you is just going to be unresponsive. So they weren't alert when you walked in, they weren't alert when you started talking to them, and they weren't alert to pain, but they do have a pulse and they are breathing. They're just going to be unresponsive. Or even if they don't have a pulse and they are not breathing, they're going to be unresponsive at that point. And then that's going to change your course of action. With determining the level of consciousness, in your scenarios and even in real life, at some point you want to ask the patient 4 questions. This is just going to be your A and O questions, or your alert and oriented questions. A person can be A and O times 0, or they can be A and O times 4. The A and O questions are just going to be for alert to person, place, time, and event. And so some questions you can ask this person is, hey, what's your name? If they can answer, they know their name, then they know the person. You just knock that off. They're at least ANO1 at this point. And then you go ahead and ask them, hey, do you know where we are right now? Do you know what city we're in? Do you know what state we're in? If they do, that's going to tell you that they are at least ANO times 2. And then the third question, time, you're just going to ask them, hey, what day is it? What month is it? Do you know the time right now? Do you know who the president is? If they do, that's going to tell you that they are at least ANO times 3. And then after that, you can even ask them that 4th question, and that 4th question is just going to be for event. So, what happened today? Why'd you call us? Why are we here? If they can answer that, then they are going to be ANO times 4. And then once they answer that event question, that's then going to start telling us what the chief complaint is, or we're going to start figuring out what their life threats are. So moving on down the list, we have our assess the airway and our breathing. So for this, you just want to see if the airway is patent. Is the person able to talk to you? Is there any gurgling sounds? Does there appear to be some sort of an obstruction in their airway? If there is, clear it. If there's not, then we're good, right? And then we're going to go ahead and assure adequate ventilations. So we're going to be looking for that tracheal tugging. We're going to be looking for the intercostal muscle use, the accessory muscle use. We can even also take lung sounds at this point. Make sure that they're clear. There's no wheezing, stridor, rales, rhonchi, crackles. Just make sure that they are normal lung sounds. And then at this point, if the patient appears to be in some sort of distress, we can just go ahead and throw them on some sort of oxygen. For your test, for this medical assessment at your school, it's probably just going to be high flow oxygen, 15 liters a minute via a non-rebreather mask. In real life, it might be as simple as just a nasal cannula at 1 liter per minute just for comfort. And then moving on, we have assess circulation. So the first point is just going to be control major bleeding. But if you arrive on scene and you see any major bleeding, that's going to take priority over everything else. So we're going to make sure to take care of that first. But If we didn't take care of that before, we're going to take care of it now and try to stop that bleeding. And then we're going to check for a pulse. We're going to check for a radial pulse on our conscious patients and then a carotid pulse on our unconscious patients. And then just make sure you assess the skin. You're going to be looking at the CTC, or the skin color, temperature, and condition. So is it pink, warm, dry? Is it pale, cool, diaphoretic? Just some descriptors you can use. And then from this very basic assessment that we just got done doing, the ABCs, we're then going to figure out pretty quickly if this person is critical, if they're not critical, can we stay and play, or do we need to load and go and get them to a hospital? And that'll determine, or help us determine, what the patient's priority is and if we should start going towards the hospital or if we should stay on scene and try to figure some more things out. Maybe ask some more questions to the patient or to the family. But questioning can also be done in transport. So for your school scenario, just say what you think you should do. If you think you should just go ahead and start transporting, in your school scenario, just go ahead and start transporting. If you think you want to stay on scene a little bit longer, then stay on scene. If you do decide to stay on scene for your scenario, just as you start getting down to right around here, that secondary assessment, just start making sure that you're saying to your proctor that we're going to start going towards the hospital now. But anyway, moving on to our history taking. So we're going to start with our OPQRST, our onset, provocation, quality, radiation, severity, and time. So the onset is just going to be, did your symptoms begin fast or slow? Did they come on immediately within seconds, or did they take hours, days even, to get this bad? And then we have our provocation. Does anything make it better or worse? Does sitting upright make it better? Does laying back make it worse? And then our quality, does it feel like somebody's sitting on your chest? Does it feel like somebody's stabbing you with a pencil? Does it feel like somebody's burning you with a lighter? That's going to be some descriptors for your quality. And then you want to ask about radiation. Does your chest pain radiate anywhere else to your body? Does it radiate to your back? Do you have pain in your stomach with that chest pain? Your severity is just going to be on a scale from 1 to 10, 10 being the worst pain you've ever felt in your life. What would you rate your current pain level at? And then T is for time. The time is just going to be, so what about, or when about did this start? When did you start noticing these symptoms? And then just make sure you start to clarify anything that you want clarified, really. Just ask follow-up questions. Your sample and OPQRST are just the very basics. You can dive as deep into it as you want. So ask clarifying questions. You have a patient who is having difficulty breathing, they're having wheezing, they have a history of asthma and COPD, because that's stuff that they've told you. You can ask them, have you tried using your inhaler yet? Have you tried any other breathing treatments? Have you ever been intubated at the hospital for this condition? Those are just going to be some clarifying questions, or just questions to dive deeper into their illness. And then past medical history. This is going to be your sample. Right here is just going to be ample. The S, the signs and symptoms, are already going to be kind of taken care of. Signs are going to be anything that you see. So you walk in and you see the patient hunched over using intercostal muscles. You see the tracheal tugging. The patient appears to be in distress. That's going to be stuff you see. Symptoms, on the other hand, are going to be things that you're told. The patient are going to tell you they're feeling this way. The patient's going to tell you, it's hard to breathe. I can't take a deep breath in. Those are going to be more of your symptoms. So, with this past medical history, you just want to ask the patient about any allergies. Do you have any medication allergies I should know of? Sulfa medications, penicillins, amoxicillins. Those are going to be a couple of the most common medication allergies somebody might have. And you want to ask if the patient is taking any medications for any conditions. Are you taking any blood thinners? Are you taking any albuterol? And if they tell you a medication and you don't know what it is, look it up. You can let them know, hey, I'm just going to pull up my phone and look up that medication real quick. Or, hey, can you tell me what that medication is and what it's for? There's no shame in not knowing. There is shame in pretending that you know something when you really don't. And then you always want to ask about past medical history. So I'll just ask the patients, hey, do you have any heart problems, lung problems, asthma, diabetes, just anything I should know about your past medical history. And I always find listing a few things out like that kind of helps jog the memory of patients and just kind of lets them know what you're kind of looking for as far as medical history goes. Because some patients will just say that they have no medical history because you didn't really ask anything specific. And then you have other patients who will tell you about their hangnail removal 26 years ago. And then you just want to ask about the last oral intake the patient had. And so just, hey, what was the last thing you ate or drank? When was that? Is that normal for you? A normal amount? Did you try it from a new place? Any drugs or alcohol? Those are all going to be some follow-up questions that you can ask. And then you're going to ask about events leading. So what were you doing before this all started? What were you doing when it got worse? And that's just going to be a little bit of your history taking. So then we're going to go down to the secondary assessment. And with medical, you don't have to assess the entire body. You can stay more focused on your assessment to the body part or the body system that's involved within their illness or their condition. So then now we're going to move on to vital signs. And vital signs, you can start getting those done as soon as you start seeing the patient. So you walk in and you tell your partner, whether this is real life or for your scenario, like, hey, go get me a set of vital signs. I want a blood pressure, a pulse, a respiratory rate and quality. I want a blood sugar. I want a temperature reading. I want an SpO2 percentage. And you can start getting this stuff done as soon as you see the patient. But if you don't get it done as soon as you see the patient, make sure you get it done at some point within your assessment. You should always aim for at least 2 sets of vitals so that you can trend the vital signs. Make sure that there's no significant changes, or if there is any significant changes, you want to be able to track those changes and how often they're significantly changing and what occurred before they changed. And then moving on, you're just going to state the field impression of the patient. So for your scenario, you'll just say, this person appears to be sick. Because of my assessment of them, I think that they're suffering from an asthma attack, for example. Because of my assessment, I believe that they are suffering from a heart attack, for example. And then we have our interventions down here. So with interventions, before you give any medications, you want to make sure or ask about past medical history, allergies, medications. Get a set of vital signs before you give any medications, because you're trying to look for any and all contraindications before you start giving somebody something. So some interventions for somebody having a heart attack. You'll say, I'll give them 324 milligrams of chewable baby aspirin, let them chew that stuff up. And then I'm going to assist them with their nitro and give them 1.4 milligram spray underneath their tongue. And then at this point, if you haven't already, start saying in your scenario, we're going to start transporting the patient, and I'm either going to go emergent or non-emergent. You just have to decide. And then we're going to go ahead and start doing our reassessment of the patient. The reassessment is done after your interventions, essentially, because you want to see if your interventions have changed at all, or if the patient's conditions have changed, whether positive or negative. If it's negative, try to figure out what else you can do, call for orders maybe, and try to see what else you can do to try to bring them back towards that positive side. And then in real life, or even for your scenario, you want to make sure that you give a verbal report. This says to arriving EMS units, which could happen on scene if there's multiple patients. You'll have to tell everybody who shows up exactly what's going on and who they need to prioritize and why. But also, this verbal report can just be to the hospital. You know, you need to give them a biophone or a radio report when you're bringing a patient in. And so something like that would just kind of sound like this. So you'll start with hospital medic 2, wait for a response. Medic 2 is coming to you guys non-emergent with a 48-year-old male patient. Chief complaint today is going to be some center crushing chest pain that started roughly 15 minutes ago. The patient was cutting their yard when this chest pain occurred. The patient's ANO4 with a GCS of 15. They're pale, cool, diaphoretic. We gave them 324 milligrams of chewable baby aspirin and assisted them with 0.4 milligrams of their nitro spray. They currently rate their pain at a 4 out of 10, and their vital signs are as follows. Blood pressure 136/88, heart rate of 88, respiratory rate at 20, SpO2 level is 98% room air, BGL is 112, and temp is 98.2. We're about 5 minutes out. Any questions? And that's basically it. That's basically going to be your patient assessment for the medical side of things. Hopefully this gave you guys a pretty good insight onto what to expect at school, but also a little bit in person in real life, because it is very similar as far as the assessments go. It just kind of comes down to eventually learning your own flow and how you want to kind of run things and ask questions. And as you do it more often, you'll learn what questions should be prioritized, what questions can wait, how fast to ask these questions, who to ask these questions to, and just all of that good stuff. So that's it for this video. Good luck to everybody.